All right, everyone, welcome to our 2023 today is renal. Oh, the Zoom quit automatically, but I'm still here. That's weird.
Still in the system.
Welcome. Yeah, I know. All right. So I'm gonna let Dr. Paul Adams take it away from here. Most of you already know him, but in case you don't,
Great.
this is Dr.
Well, I'm Paul Adams. I do nephrology and critical care. You'll see me around. So I'll tell you about some CRRT here. This is really kind of like, it's semi-case based. So we'll go through a case and kind of learn some things along the way. So this is somewhat of a, rambling thing of what I think we might want to know, just some highlights, what we'll touch on. So first things first, why do we care? A good deal of ICU patients, right about 2/3, are going to end up with some kind of AKI. That doesn't mean they're on dialysis or whatever, right? But like some portion, a good chunk of them are going to end up with complications of kidney disease during their ICU stay. They usually end up staying in the hospital longer. They're sicker. They may have ESRD more often, but the big thing is they die more often if they have a kidney injury. How much more? Quite a bit. This is old data, but it stacks up. Nobody's really bothered to look at this again, just because it doesn't change. And as Brian can tell you, we just looked at all of our CRRT numbers for the past year at UK, and we're right at about 60% or so of hospital mortality for those that get started on dialysis and have a bad AKI, right? So this far right hand group is who we're looking at. So that's anybody in the ICU that gets started on dialysis. About 60% of them die within the hospital. That's a pretty bad number. Well, that was quick. So this is our first kind of introduction, where we'll follow this case through. So it's kind of a lot of words here. I'll hit the highlights. This is a 60-something-year-old guy with history of diverticulosis, comes in, abdominal pain. He looks kind of septic, so they're going to admit him. Hypotensive when he hits the ER, a little bit of an elevated lactate. He gets 4 liters of fluid, gets a little better. So they get him upstairs, basically, stops really making a ton of urine, less than 0.5 ml per kg per hour. So dropped off, not terribly adequate. UA, it's got a little bit of cast in there. Urine sodium is low. This is all just kind of like rambling things that the intern tells you about. BNP is creatinine. His creatinine's like 1.2. His baseline's around there. You're not really concerned. Vitals look decent, right? So the first thing to do is you say, okay, well, is there anything we want to change? And then do we want to recognize whether or not this patient has an AKI? We'll just take a moment, search your feelings, see what you think. And we'll go on and say, well, we'll look at his urine. This is what his urine, what his urine looks like in there. We're going to decide whether or not he has an AKI. We're going to kind of go through this. And first we say, we get a urine with micro. This is going to be our most helpful test. What you're seeing over here, these are granular casts. You're not going to ever look at these. I just throw it up here. Granular cast. This is basically just dead kidney cells within the tubules that you pee out. Pretty sensitive for saying, yeah, you have an AKI from ischemia or, like dead cells in the kidney from being septic. The FENA, I don't really care about the FENA. The FENA is garbage. This is fractional excretion of sodium. People tell me about it all the time, but it has no use in our setting. It just needs to go away. The real money is deciding if somebody has ATN or acute tubular necrosis, which is basically just like your kidneys didn't do enough blood flow. You get granular casts, RTE cells, which is just renal tubular cells in the urine. It just tells you that the cells died, right? And that's what we're after to say, okay, well, that's the reason for what's happening. So learning points here, we'll look at our AKI staging, right? So to say, well, does this person have an AKI or not? I throw this up here. This is one organization. This is KDIGO, as you see up here. There's I don't even know, probably 6 of these at this point. KDIGO, Rifle, Akin, everybody and their brother comes up with some kind of AKI staging, and it's all research driven, right? It's just so you can say, oh, this person has a stage 1 or stage 2 or stage 3 AKI, so you can write a paper about it and like have nice, neat little groups. I wouldn't worry about that so much. Like the creatinine is going to go up by a whole lot. And then we're going to notice that they have, decreased urine output, right? Like that's how this is going to go, depending on no matter whose criteria you use. The big thing though to remember is that urine output is a criteria in all of these. And urine output is always going to come first. Creatinine always lags, because it has to accumulate before it really starts to go up. So like in this guy's case, it can also be diluted by some IV fluid resuscitation, right? You got 4 liters of fluid. Does that creatinine really reflect what's happening? So number one learning point, watch the urine, 0.5 ml per kg. That's the easy number to stick in your head. And if you notice, nobody really cares until it's 6 hours, 12 hours, right? 24 hours. Hour to hour urine output is going to vary, right? I mean, if it's a little less 1 hour and then up the next hour, right? I mean, we're kind of looking for an average over 6 or 12 hours. I wish we had something more sensitive than that, but that's about all we got. And this second bullet point over here, ischemic ATN, associated with severe sepsis, right? That's what this guy has. More volume doesn't really have a role, right? So this is like, for the, some people may say, oh, well, I mean, maybe urine output's down a little bit, maybe he needs a little bit more fluid. Well, I mean, he could, but there are other methods, right? Like that's probably a more hemodynamic measurement, right? Like that's a whole nother topic, but just for urine output and ATN really doesn't have a role, right? Like the more fluid I give him, his kidneys they're damaged. The cells died. Like more fluid is not going to change that. It's probably going to actually be harmful, because it's going to lead to further volume overload in somebody who's not peeing very well already. And then in this case, like at this stage, I throw diuretics up here too, just in case you're like, oh, he's not peeing. Like we could give him some volume, some Lasix. Like, yeah, I mean, you could. I mean, you could test his kidney function that way, and we'll get into that. But at this point, like probably a little early on for that, right? This is just supportive care. Just try to fix the other numbers associated with this kidney disease at this point. So, and we'll move on to causes of kidney failure in the hospital. As you see, this giant half of the pie is tubular necrosis. In other words, your cells just died because they didn't get enough blood flow where we gave them a toxin. These other things over here, pre-renal, this is where you do respond to fluid. I'll tell you, 9 times out of 10, by the time you get to the ICU, they have been given enough fluid. They're in the yellow giant ATN pie wedge, right? You can pick out these pre-renal folks, right? These are the people that are like found down and look like a potato chip, and they're making urine as fast as you give them fluid, right? Like it's not really, it's pretty obvious. And then the rest of these, are kind of up to nephrology to figure out. Like obstruction, I guess that's another easy one. You put it fully in, they make 3 liters of urine immediately. Well, like they were probably obstructed, right? That one fixes itself. I throw this up here just so we know, like there's some overlap between chronic kidney disease or CKD and then AKI, the acute version, right? If you have chronic disease, you're more likely to get an AKI, right? You're playing with a deck's already kind of stacked against you. You got less reserve. If you have an AKI, depending how bad it is, right, you're more likely to develop CKD later in life. So we just have to remember that these are two like separate but related kind of entities as we talk about, kidney injury and how this evolves within the hospital. So we'll continue this guy's journey. So the next morning, he's made only 75 mils overnight. He got 2 liters of normal saline for decreased urine output overnight. As we know, that probably didn't do a whole lot. New labs, sodium, whatever, this stuff's all pretty normal, all okay, except, I mean, his bicarb is low, right? His creatinine is up. It pretty much doubled since yesterday. Somebody get a gas. Its pH is 7.2, PCO2 is 44, O2 is like fine. Vitals, little hypoxic, little hypotense, right? Like kind of like worse, just a smidge worse than yesterday, right? So just to sum this up, we have a guy that's not peeing. Its vitals are a little bit worse. Labs are a little bit worse. Doesn't seem really responsive to fluid. On rounds, you know, he's tachypnic, he's hypotense, he's got worsening pain, now encephalopathic, which is a big change. And so this is just looks like it's getting worse. And this, you know, this dyspnea and things, they're just going to intubate him, right? So they do that. With this, you know, of course, he drops his pressure. He gets 2 more liters of fluid around this, you know, decompensation. He gets started on norepinephrine. We take a look at him after intubation. Here is his gas, 7.0, PCO2 46, PO2 in the 80s, BNP kind of the same. I mean, like this is 4 hours different. His chest X-ray looks pretty bad. It's got air space disease bilaterally. And then his vitals, right? Like through his den settings on here, you know, 60% of FiO2, beep at 10. He's sat and still in the low 90s, right? So not great. So if we notice, this guy has a new and now worsening acidosis, and then new and worsening hypoxia over the course of, right, like 12 hours since the last time we saw him. So I'll let you kind of think, what do we think about this, and what do we want to do about it? Is there anything that we want to change? Some learning points here as we kind of deconstruct this. This guy, you know, when I ask what do we think about his acidosis, what is the anion gap metabolic acidosis, right? With poor respiratory compensation. We know that, I mean, if you do the math here, he's got a gap, or you don't have to do the math and you can just look at the, you know, it tells you an epic. His gap is high, right? Like it's on there. And he has volume overload with pulmonary edema, right? The chest X-ray shows us that. Turns out if your lungs are full of fluid, you can't exchange gas, and your PCO2 goes up, your oxygen goes down, right? So he can't really compensate well. He can't blow out that CO2 to make up for all this, you know, acid that is building up from his metabolic dysfunction of sepsis. And this is probably related to his fluid overload, right? Like, this is my point earlier, you know, when I flashed up those stats about, you know, people with AKI ending up on the vent more, you know, longer time in the ICU, more time on the vent, because of stuff like this, right? They get a bunch of fluid, they can't pee it out, and then they do worse. You know, this guy can't exchange gas now very well. So now this guy went from a should be easy to ventilate patient with no lung disease, right? He's here with an abdominal source of sepsis, to now somebody who's difficult to ventilate, all because he got too much fluid. And that's just a learning point with AKI. They're you know, they don't make any urine, so they're very, very sensitive to how much volume you give them, right? This guy's probably getting, you know, Vanx, Docin, you know, he's on Levophed now he's going to need propofol, you know, maybe some Dilaudid, right? So it's very easy to see how he would take in 2 and 3 liters a day, even aside from resuscitation, right? None of that comes out. So we'll reframe this. He's volume overloaded. He's not peeing. He's in shock. Doesn't seem like things are getting better anytime soon. Is this the time we have to make a move, right? So before we decide what we want to do, we'll just talk about renal replacement therapy and what it can do. So really what you need to do to make it different, right, is exchange about 30 liters of plasma, right? I mean, your usual plasma volume, you know, plasma being the liquid portion of the blood, you know, it's usually maybe like 3-4 liters in someone, right? So you got to exchange, you know, roughly 10 times that, right? So 30 liters a day to really kind of make a dent in someone's physiology, right? So for 70-kilo patient, we do occasionally get those in the ICU. If you do hemodialysis, right, I just throw in a blood flow right here, 400. That's usually what we run. You know, if you do the math here, that you'll clean that 30 liters in about an hour and 15 minutes, right? For CRRT, to put this in perspective, this is an effluent dose, right? Our mils per kg per hour. It's going to take about 17 hours to even start to make that dent, right? So you can really clearly see the difference between the clearance capabilities of both of those. CRRT is like way less efficient, right? So this is kind of like why I will always roll my eyes when people say, oh, we need emergent CRRT. Well, we need an emergent therapy that takes you know, almost 24 hours to work. Like, it's a bit of an oxymoron, right? If we need to change something now, we just put them on hemo and, you know, damn the torpedoes. We'll just put them on suppressors and forget about it. If you notice, right, like we usually run people on hemo for, right, 3-4 hours. We usually run CRT, you know, 24 hours a day, right? It's because this is not 100% efficient. You get some recirculation, where the catheter picks up already clean blood, right? You get some, you know, ongoing metabolism that puts products back into the blood, right? So that's why, you know, these numbers are ideal state, right? So usually we got to go longer than that. A little bit more comparison, right? Like we already said, HD is more efficient. You can get more done in less time. Big issue with hemo though is that it's, you know, people are unstable, right? So 10% of people you just can't do it, right? But that's a small number, right? 10%. Like we just need to try, right? And not look at the blood pressure, or not, maybe not look at it, right? But just give some pressors and say it's going to be okay. If you meet Eric, the dialysis nurse, he'll run just about anything. CRRT, right? Definitely more hemodynamically stable. Anybody should tolerate CRRT. Like if we're not, we have a bigger conversation to have. HD, you can use a fistula or a graft if they already have one of those, which is nice. CRT, you got to use a catheter. No way around that, at least for us. Hemo, you need an HD nurse, right? So, you know, I mean, those are in high demand right now. It's always hard to get one and a machine, right? Because they're busy. But here in Kentucky, we can use the ICU nurses for CRT. So that's nice. You may be asking, is there evidence between these two things? Well, not really. Like here's a bunch of studies, a ton of patients, right? You got 2 of these individual ones, and you get the big meta-analysis. So this is like thousands of patients at this point. It really says there's no difference between the 2 therapies. When you look at like large numbers of people, one is not necessarily better than the other when it comes to outcomes like mortality and things like that. But when you really think about it, right, it's kind of like asking what's better, like a standard or a Phillips head screwdriver. You know, like, you just need to pick the right tool for the job. Like both screwdrivers work, right? But you need one that matches the job at hand, right? If somebody is very, very unstable and you don't really have an urgent need to clean anything out of the blood, and you just, you know, kind of want that therapy on board to manage volume and to make sure they're not hyperkalemic like tomorrow, then CRT is fine, right? But if somebody's potassium is 7 and they have EKG changes, right, like you can't wait 24 hours. I don't care what their blood pressure is. Like they need hemo like right now. Same thing with toxins and things like that, right? So it's just pick the right tool for the job. That's all that is. You may ask, well, why would we delay dialysis, right? Like, why do we sit there and say, oh, well, we'll check on this guy tomorrow, you know? I mean, there's some reasons, right? There's procedural risk, right? You got to put the line in, you know, you gotta, you know, there's people get on machine, they might have arrhythmias, hypertension, there's a big risk for infection, right? Most of our collapses in the hospital are dialysis catheter related, and that's mainly just due to the length of time it stays in there, right? There's theories about, you know, whether or not somebody goes to dialysis, it causes more inflammation or some reperfusion injuries. And then I'll touch on this in a minute. Like a lot of these people that we put on therapy ends up just like not even needing it, right? 20-30% of those people sometimes. So you kind of feel a little bit bad when you're like, oh, we started them on CRT and then they made urine like 12 hours later. It's a little embarrassing. So I'd rather just like not do that. These are a series of studies that kind of started asking this question of like, when do you put somebody on? Do we want to do it early, just, you know, just to say we did it, or do we want to wait until the absolute bitter end? So Elaine and Akiki were like the first 2. They asked a good question, but they were kind of terribly designed. And then Ideal ICU and then Start AKI came out. And Start AKI was kind of like the big boss final word. Big, well-designed study. And it basically just said, there's really no difference between starting early, like when that creatinine starts going up, they stop making urine, or just waiting until, you know, they hit a hard indication. There's no difference. So practice is kind of like, well, let's just wait until they have an indication, and then we'll start. That being said, I think volume overload is, for me, like we should start that early. We should avoid that. It's very much a theme of this presentation is, you know, I don't really care what the BUN is. I don't really care what the creatinine is, right? Like nobody ever died from creatinine toxicity. That's not a thing, right? But like people do die a lot from volume overload. There's a lot of evidence to support that. And if we can put somebody that's not making urine on CRRT and control that and prevent them from being overloaded, that in my mind is gonna make a big difference. That has not really been studied yet. As far as like prevention, but we'll get there. So learning ports here, no really time, or trigger or something like that for CRT or dialysis, but early consultation with nephrology does help. So, sometimes people like think they can just, tough it out and figure it out, but like just call nephrology, right? Like this is our entire job. CRT and HD, like just know which tool you're using. There's really no advantage, on paper, but they have pros and cons. I feel like this is kind of a myth out there that we just need to dispel, right? Like if you're on 0.02 of Levophed, like you can go on hemo. I think my personal record on hemo is like 1.5 of epi or something stupid, right? The lady had metformin toxicity, right? Like it was either you go on hemo or you die, right? She survived, fine, walked out of the hospital, so we can get people through the therapy. We just need the tools to do it. Yeah, HD better at moving toxins, but just a little harder to get there. So with this guy, we decided to start CRRT, put a dialysis catheter in the right IJ, tips in the right atrium, which is right where we want it to be. You get best blood flow there. If it's too shallow, you won't get good flow. And so here's our orders: CVV-HDF with citrate. This is our old protocol. Look at that. That's okay. I just noticed that. So blood flow 250, pre 250, dialysate 1500, post to 1500, and then UF net even to net negative 50, right? And the question always comes is like, well, do you really want to pull fluid? Like he's on pressors. What do we think? So we'll get to that question in a minute. I just kind of want to hit these points, right? So just so we all are on the same page, right? If the intern shows up to throw a 24 centimeter or something in the right IJ, that's probably fine, but they're going to need to leave like a pretty good tail, right? Or if they show up to put a 20 centimeter or even worse, like a 15 centimeter that are somehow still floating around the hospital in the FEM, that's not going to work, right? So what we're going to do is we're going to put 20 centimeters in the right IJ or the left, and leave a little bit of tail there. You can put a 24 there and leave a lot of tail. That's, I guess, fine. But if we're going to put it in the FEM or the left, we should use a longer catheter just because we want that tip at the right IJ. Or I mean, sorry, at the right atrium. We use CVHDF most of the time. And this is back to my volume, my UF question. Like this guy's clearly volume overloaded. I think net even is not out of the question at all, right? Like that's what goes in comes out. Like we're not changing his volume status at all. So we're actually just preventing him from being overloaded. And then I think just like a little bit of net negative fluid balance is also not going to help this guy. Yeah, he's on pressors, but like prove to me somehow that he is going to be poorly perfused because we're taking off 50 mils an hour. That's like a shot glass, right? Like it's nothing. He probably gets more than that drawn with morning labs, So I think this guy's, in his case, he's volume overloaded. He can't breathe. He's on the ventilator. He's got edema, pull a little bit. We can try it. Just see what happens. And then, bring us up in nephrology. Like, believe it or not, we care. We want to know if people are tolerating UF, what the primary team thinks. This is a big part of our job is, trying to decide like how much UF, when and how, and manage volume overload. So access, a little bit about access. This is the most common, and I keep harping on this because it's a big deal, right? This is the most common reason for a set clot. Zero UF, yeah, relatively rare. We do it. Yeah, like Brian said, you get scared, right? Like, it really shouldn't change much, right? Whether you're net even or right, like this is per hour changes, so we're taking off very, very little, even at net even, right? And what goes in is we're taking it out. So we're really not making any changes there. I keep harping on access because, you know, if you look at any literature, you know, and even our stuff here, you know, at UK, it's the most common reason why the set goes down, right? And that's what you'll see on the machine. The axis of the return pressure becomes very negative or very positive, and then the machine goes down, right? So right agile is best at 20 centimeters. That's just a straight shot. FEM is next best, and that's a 24. This becomes like maybe less evidence-based, but like still had some out there that says the left IJ is probably the worst. And that's mainly just because it's got to make that big turn, you know, coming down the neck and into the atrium. So it causes a little bit of, you know, resistance there. So when I just throw these number on here, if they're real small, like I said before, they're going to have to lead up a little bit of the tail. It should raise some eyebrows, right? If this lady is like, you know, some patient is, you know, some 5'2" lady, and she's got a 20 centimeter and a right IJ that's like hubbed, you know, because the intern just like didn't think about it, right? So just so you know. And then if they're two more Kentucky units, or, you know, like 200 kilos or so, right? 20 centimeter, probably going to be fine, but we should probably stick that a little bit more all the way in, right? So just so you know, you're like, why is my machine not running? Look at the access first. So a little bit about how dialysis works. Here is our dialysis machine with our dialysis patient on there. This is through diffusion, right? So you pass a fluid near the blood through these, you know, hollow fibers of the filter, and water will move from, you know, high concentration to low concentration, and then solute does the opposite. It moves from low concentration to high concentration, right? So if somebody's potassium is 6 and we're running them on a 2K potassium bath, the fluid has lower potassium in it, the K just goes downhill. It's concentration gradient, right? Small molecules, I guess that's take on here. And then convection is what we do with replacement fluid, so pre and post, right? So that's a pressure gradient. The machine is, you know, pushing and pulling fluid across the membrane, and solute just kind of like goes with it. This clears more middle molecules. UF is also convection, right? So there's really no difference in the acute setting. Like, no one cares when you do the convection or dialysis. It's the same. Here's our filter, right? So hollow fibers that you're running blood around, right, or through the fibers, and then fluid is dialysate is surrounding them. These are synthetic. I think the CRRT filters are polyacrylonitrile. The point here is that synthetic filters rarely cause a dialysis reaction, like a filter reaction. The old ones were made from cellulose, which is the natural fiber, and people reacted that quite a bit. But, you know, somebody says, oh, well, then maybe have a filter reaction. Like, I doubt it. So hemodialysis inpatient, you know, I'll just touch on this a little bit, just to try to shift gears away a little bit from CRRT, just to let us know. So this is like I said before, rapid clearance of solute or volume, right? So we can clear your total body water, right, which is usually, you know, 40-50 liters of water, right, within a couple of hours, 2 to 3 hours. So we can clean everything out in 2 or 3 hours, and you know, in that same 2 or 3 hours, if we're really cooking, we can get 3 or 4 liters off. Doesn't happen if you're hypotensive, but we can do it if we need to, right? So this is for like acute acidosis, acute issues with potassium, you know, intoxications with different drugs, you know, like bad volume overload. Although I'm yet to be proven wrong that when I say if you're debating between intubation and dialysis, you need to intubate that patient every time, right? It's not that good. And then uremia, right? Emergent HD, you know, things like that. Well, we got to get this cleaned up like right now. And when I say emergent HD, you need to get all of these things like in the room together at the same time. The nurse, the machine, a water source, right? Like that usually takes 2 or 3 hours. So when I say emergent, I have there in quotes, right? Like this can't just happen in 20 minutes. It's going to take a little bit, but we should feel a sense of urgency. So back to CRRT a bit. We're kind of done with hemo now. just looking at different modalities, right? So there's CVVHD, which is just dialysis, CVVH, which is hemofiltration, which is just that convection, so just replacement fluid, and then HDF, which is the combination. There's really no difference. Doesn't matter. Just pick one. We use HDF because it's pretty flexible. Like I said, here's the data to show you that it just doesn't matter. You just pick one. This is a throwback. This is Javier. Brian's laughing. This is our old CRRT director. He was just like absolutely obsessed with filter life. Well, and while it's important, you know, I mean, like other things I think are also important too. So we definitely, like, this goes without saying, we want to minimize filter loss, right? These things can last 72 hours, and we definitely kind of want them to get there if we can. The big thing there is the filtration fraction, and then the anticoagulation with that. So we'll touch on that. I think I talk about filtration fraction. There's really, when you're writing a prescription, like I said before, there's nothing that's like better than the other one. I personally try to just like make your job easier, right? Like I'm not going to put 3 different rates on 3 different pumps if I can help it. So that way you're not, you know, you're changing bags at like kind of the same time, not like, you know, every half an hour you're trying to do something. So what makes a filter clot? How do we reduce downtime, and how's that play into the prescription? Well, hemoconcentration, right? So if you just set this all up to pull, you know, 3 liters of post-filter replacement, that blood is going to get super concentrated in there. And that's the concept of a filtration fraction, right? So like what goes into the filter versus what comes out of the filter, right? So if you're concentrating that blood, it's probably going to clot more. And then stasis in the filter too, right? Like if this person is moving all around, or they have a not so great access, and the machine will stop an alarm, and then you got to go reset it, right? Like that blood sitting in the filter, it's gonna clot eventually, right? So the dose, how do we come up with this? This is otherwise known as the effluent dose, right? This is the yellow bag. Here's some studies that they did to decide, well, sometimes we'll put people on, you know, 20 mils per kg per hour versus, you know, 35. And then they said 25 versus 40. Right. And this is you find the effluent by saying, oh, well, you add up the the dialysate, and the post, you know, and let's say that's 3 liters, right? You got a 100 kilo patient. That would be 30 mils per kg, right, per hour. So it's kind of normalized for weight. So as you look at this, they said, well, there's really not a difference between 20 and 35. There really was a difference between 25 and 40. So we're just going to say, let's stick with about 20 or 25. We shoot a little higher, right? If you notice, your effluents are probably in the 20s and 30s, you know, maybe pushing 40 sometimes if they're small, because we're looking for downtime. Right, this person's going to go, you know, maybe off to a procedure, right? Maybe their septic clot, like Benzonude might send them for 5 CT scans, you know, so they might be off that machine for 2-3 hours a day, and we're looking at this as a 24-hour therapy, right? So if we put them on 30 and they're off the machine for a couple of hours and they only get 25, like then we're fine, right? So the different fluids we use, Foxillum. It's kind of in the name that says phos in it, so it's nice because we don't have to replace it. So the 4O, so we use the citrate. It's, you know, 4 potassium, no calcium. Prismasate does not have phos in it. It has 2 potassium and then 0 calcium. I throw hyperkalemia question mark. If we're using CRRT for hyperkalemia, I think we're screwed. Because, you know, as I said before, the clearance is just not going to be there. You can get away with it occasionally, but I just don't really like to do this. I feel like there's always a shortage of it too, so it's annoying. You can use bicarb as well on their post filter. Again, this is like, if we're reaching for this, like, what are we doing? I've only seen it really work a handful of times where it's been helpful, but you can do it. This is like a case-by-case basis though. And then we can customize that too. Like you can run D5, you can run hypertonic, you can run any combination of whatever you want on there, you know. This is usually helpful for people that have sodium issues, right? So anticoagulation. This is like a whole topic in itself, but we'll touch on this. So what causes clotting? Well, it's right, it's anything that how's your blood clot? Fibrin deposits, right? You know, fibrin accumulates in the filter, it gums it up, and then the blood starts to stick to it and forms a clot, just like you would if you cut yourself. You can use heparin to get around that, right? It's used systemically. You start a heparin drip, you put them on CRRT, call it a day. Well, people can develop heparin resistance, you can get hit, and then, you know, you're systemically anticoagulating somebody so they can bleed. Or you can use citrate. Citrate is great because it's regional. It only anticoagulates the set, and it's proven to cause, you know, to lead to less clotting, more, you know, uptime of the machine, less kind of overall work, hopefully. But there's really no difference in mortality and things like that. So citrate works by binding up calcium, right? And so you need calcium for basically every step of clotting. So if you get your ICAL down like less than 1, you'll just bleed forever. We kind of get it in the 2 range, right? And that's your Prisma ICAL, right? So the one you test on the machine, we're shooting for about 2, more or less. This calcium and citrate complex, when it's combined together, gets removed from the CRRT machine or by the CRRT, right? It just goes off in your effluent, meaning that the patient is now without some calcium, but we just give it back via the drip, right? A little bit makes it back to the patient. The liver metabolizes it, not a big deal. And this is why somebody has to have a working liver, right, to go on citrate, because that little bit is going to make it back to them. So, and then, like I said, we replace it. Sometimes we'll run. I'm really a big fan of running this like 425 calcium Foxcell and post filter. I think it really helps smooth things out, but I'm trying to prove that data collection is a pain. So this is just a schematic, right, of anticoagulation setup, just so we can kind of look at it, right? So it's just, you know, as soon as it comes in from the patient, you got your anticoagulation coming in. It's the first thing that hit the blood. It's your pre, you know, we can give some post filter here, right? The fluid is being pulled off here, and then you got the calcium drip going back into the patient to return that. So citrate disadvantages. Well, if you end up with too much citrate in you, it can be toxic. Or if you forget to run the calcium drip or whatever, you can become hypocalcemic. Citrate is an acid, so you can become acidotic if your liver doesn't work and it accumulates, or if your liver works and we just give you too much, it can just metabolize to bicarb and you become alkalotic. The citrate, most citrate is sodium citrate. We use a 4% sodium citrate solution. That's a lot of sodium, right? So if we give you too much of it, you become hypernatremic. And like I said, it can accumulate, it can convert it to bicarb. So overnight calcium calls, to me, that's the biggest disadvantage, is we have to talk to each other about the calcium all the time, even though we know it's probably okay. It's just like a lot of, like, once you get the drip going and they're stable, it's great. I feel like it runs itself, but sometimes people, you know, they're just persistently hypocalcemic, and we just need to cut that off and give them calcium. That's a whole nother topic, but we'll leave it at that. Filtration fraction. This is what I talked about before. This is kind of the what goes out versus what comes in. And I throw this equation up here just so we can look at it and appreciate it. So what comes out of the filter, right? We're looking to make this a small number, right? So the top number of the fraction makes it a big number if it's big, and the bottom number makes it, you know, if that the bottom number goes up, right, the fraction is smaller. So post filter and UF are on top, blood flow and pre on the bottom. You got to remember that all of these numbers are per hour, except for blood flow, which is per minute. So the biggest bang for your buck here is blood flow, right? So if we have somebody that's clotting and we can't give them citrate for whatever reason, go up on the blood flow, right? Like, that's the big thing. And that will probably be our move, just so you know our reasoning behind this. I mean, you could also just give them a bunch of pre, but it's not going to have the same, like, you know, bang for your buck as you will get with the blood flow. It also make your efficiency a little bit lower, because now you're like introducing more of a clean fluid into the blood, and then you're going to put that blood and that clean fluid through a filter, right? So you're cleaning a clean fluid that is less efficient. So That's just what I said. So, we'll move on to some volume management, and I alluded to this before. This is a distillation of like many studies, but we'll read this and appreciate it. That ATN, post-renal or obstructive disease, IV fluid doesn't really have a clear role, right? Like these people are just at risk of volume overloaded and poor outcomes, poor wound healing, right? And you could say, well, we'll give them diuretics, and that's great. That's a great way to fix their volume if they respond, but it doesn't make them get better any faster, right? The prognosis, though, this Grossbite stress test, I'll get to that in a minute. I'm a big fan. You may know this, but we'll get to that in a second. I already said that. So this guy gets worse again. Back to our patient. He's still here. So later in the day, he's maxed on levo and vaso, whatever that max is. Scan him. He's got diverticulitis and free air in his abdomen. Looks bad. We called surgery. They want to take him to the OR, but they're worried about his acidosis. They want a bicarb drip. And here's his information. So pH is 6.9, PCO2 in the 50s, bicarb is 8, GAPS 18, lactate 6. Vent settings are still the same. The bicarb and his acidosis. What should we do about that? So I throw this up here because I was tortured with it all the way through medical school, and I feel like some people should share my pain. So this is how your body more or less compensates, right, for acidosis. You look on the left, this is where the equation ends with you breathing out CO2 from your lungs. And on the right, or in the middle over here, actually, this is where like additional hydrogen ions are added, right? You get more hydrogen ions, your pH goes down, you look terrible. These hydrogen ions are coming from, basically we'll just say, dysregulated metabolism from being in septic shock. Just the lactic acid, whatever you want to say, doesn't matter. You get a hydrogen ion load. So what your body does is that transports that as with bicarb through the form of carbonic acid, right? The H gets added to the bicarb, and you blow off the CO2 and you make that carbonic acid in the water, right? So if you can't blow off CO2, if you can't ventilate, this whole thing just falls apart, and you could give them as much bicarb as you want, but you're just going to be stuck at this middle step, and you actually might worsen the issue by making carbonic acid, right? With all of that bicarb, it's got to go somewhere. If you can't make CO2, you can't get rid of the CO2, right? That's why I say, like, be careful with bicarb, because this guy has a lactic acidosis and poor respiratory compensation, right? His PCO2 is still high. It's in the 50s, right? It's going to be much easier to just blow off that CO2 than it's going to be to like give him liters and liters of bicarb trying to correct a gap acidosis, right? So you notice his respiratory rate's pretty low. It's like, I don't know, it's 15 or something. Like, put it in the 20s, make it 30, right? Do whatever you need to do on the ventilator to get him to tolerate that, because that's going to have a much bigger effect than giving a bicarb, which actually may hurt things. And like I said, this is why he's acidotic because he's in septic shock, and he's in septic shock because his bowels are ruptured, right? He's got free air in his abdomen. Like, we got to take care of that problem. And the surgeons are just going to kind of have to get over it, Acidosis disrupts cellular function. This is why it looks bad. Bicarb, there's nothing to say this helps, right? And it may actually make things worse. I'm not necessarily against giving bicarb in his case, because his bicarb is pretty low and he probably needs a little bit. Usually my cutoff is kind of like less than 10, but you got to make a plan to ventilate him, and you got to make a plan to control the extra volume that he's getting. I usually just give a couple of amps, as a push, and just see if that makes a difference in their gas, right? Like, if you give them 2 amps, wait 20 minutes, get a gas, and it's worse, well, then we should probably not do that anymore, Also, like, I feel like the knee jerk, the standard reaction is just give a liter of like, IV bicarb of 150 milliequivalents, right? In D5, it's 75 an hour. Well, like, that's nothing. I mean, it's going to take a day to give them what you can give them in, a couple of minutes with a couple of amps, you know. So my approach is to give it, assess, and see if you've done anything that's beneficial. So that's temporary. Temporary fix. So it's CRT. They're going to take him to the OR that night, but the CRT set clots. Another, you know, somebody else, maybe Brian is there and is mumbling something about his CRT, you know, access pressure being very negative. His peak pressures on the vent have starting to rise. Do we think these two things are related? If I'm asking this question, they probably are. The first thing is like talk to us about this. You know, we want to help you not put a bazillion sets on these machines, right? Like I just groan when I hear, you know, there were 5 sets put on overnight or something. I'm like, come on, like we could have helped you with that, you know, because there's usually a problem there that we can, you know, try to fix. And like I said before, most of the time, 70–80% of the time, it's a catheter, right? And in this case, this guy's case, it's a catheter, right? And so his high peak pressures on the vent, and his high probably intra-abdominal pressures, right? This guy's got abdominal sepsis, his abdomen's probably a rock, are impeding blood flow. You know, you see it all the time with ARDS, right? Stiff lungs, can't ventilate, high PEEP. Well, that catheter is in the chest too. And the blood vessels, the veins are being squeezed, and you're not getting good blood return, right? So that catheter that's not in a great position, not in the right atrium, not get good blood flow. And the, you know, machine alarms and clots. So set clots, right? Rising TMP or filter pressure. That's, you know, 200 mils of blood, right? So you change out 3 or 4 of those things. That's close to a liter of blood. We try to get to 72 hours. If we're having trouble with that, like I said, just call nephrology. We can try to troubleshoot it with you. So, and honestly, I mean, like, it's an okay answer overnight for the fellow to say, I don't know, looks like things are fine, just leave it off and they can figure it out in the morning. I mean, 6 hours off the therapy is probably better than like putting 2 more sets on, you know, wasting blood, wasting your time, wasting money, right? Because that patient's still not getting effective therapy. So just like that goes down at midnight, the fellow's at home. I mean, they take home call, like they're not, you know, they might not be able to come in and look and help, you know, work through this. So leaving it off until the day team gets there is totally fine. So are we done yet? Hopefully. He goes to the OR, he comes back. Of course, he comes back to the MICU. He's getting a little better. His pressures are decreased. We start getting some more volume off, starts getting better. He's extubated. We want to send him to the good Sam. Still in CRT, can't really transport, you know, it becomes a little weird. Nephrology says, just give him a bunch of Lasix, 200 milligrams, see what happens. So how do we know if he's ready to come off and what's up with this Lasix? So this is the much talked about Lasix stress test, right? So basically what this does is we give, you know, 1.5 mils per kg of furosemide, and they should pee a mil per kg per hour, right? If you do that, you're going to get better, right? This predicts renal recovery. If you don't do that, you're not getting better yet, right? You're probably still going to need dialysis. So that's where we're at. I think it's a good thing to do, and we might test some renal function with that to try to see if somebody can come off CRT. But you don't necessarily need to do this. So, to summarize this, AKI is a big influence on your outcome, especially with volume overload. Dialysis, CRT, just pick the right one for the job. If I had to talk about anything on CRT, you need good access, and then we need to just replace the calcium on the citrate. Like hypocalcemia on citrate is always, it's always going to be present until we actually replace it. We can't just rely on the drip. And then our goal as a CRRT, from a nursing standpoint, we want to maintain the circuit efficiently. We just want this thing to run without causing us problems as long as we can get it. And we want to make sure we control volume. So, questions there?
So if nobody has a question, as kind of part of this series, I've been asking all of our lecturers, if there was one thing that you wish nurses understood about AKI and ICU, what would it be, Dr. Adams?
usually doesn't get better with fluid. That's why you saw my pie graph there most of the time. And that was for like all the hospital, right? I mean, I feel like the ICU is even more, right? It's ATN, it's ischemia. Like the damage is already done by the time they get to you. So we just got to ride it out. So
Yeah, it's not at all uncommon for some of our patients to be 10-15% fluid
Yeah.
overloaded. On
yeah,
recharge.
liters and liters. Great.
All right, well, thank you everyone for attending, and thank you, Dr. Adams, for presenting.
Yep.
I will see you all in, I think, 2 weeks is our next
right.
one.
Thanks, team.
Thank you so much.
All right. See ya.